This is a video in clinical medicine from the New England Journal of Medicine.
Evaluation of blood pressure is essential in assessing cardiovascular health. It is used in screening for hypertension and for monitoring the effectiveness of treatment in patients with established hypertension. In the routine outpatient setting, blood pressure is measured indirectly. Thus, it is important that proper techniques be used in order to produce consistent and reliable readings. In adults, a normal blood pressure is less than 120 millimeters of mercury for systolic and less than 80 millimeters of mercury for diastolic blood pressure. Higher levels are classified as prehypertensive asystolic blood pressure between 120 and 139 millimeters of mercury and a diastolic blood pressure between 80 and 89 millimeters of mercury. Hypertension is defined as a systolic blood pressure greater than 140 millimeters of mercury or greater than 90 millimeters of mercury diastolic measurement. The purpose of this video is to demonstrate the appropriate technique for the indirect measurement of blood pressure in adults. Blood pressure should be assessed at each office visit. The equipment necessary for measuring blood pressure includes a stethoscope. The stethoscope should have tubing of sufficient length for the clinician to hear Korotkov sounds while viewing the manometer. The bell side of the stethoscope should be used as it permits better auscultation of Korotkov sounds. A sphygmomanometer consisting of a blood pressure cuff containing a distensible bladder, a rubber bulb, and an adjustable valve, as well as flexible tubing. Finally, a manometer that documents the level of pressure within the cuff. Each part of the sphygmomanometer should be examined on a regular basis. The needle on an aneroid manometer should rest at 0 before and after measuring blood pressure. Aneroid manometers should have scheduled recalibration at least every 6 months. Concerns over the toxicity and environmental impact of mercury have led many institutions to use aneroid manometers exclusively. The steps required for accurate indirect measurement of blood pressure are identical whether using an aneroid or mercury manometer. Correct positioning of the patient is essential to accurately measure blood pressure. The patient's back and legs should be supported, with legs uncrossed and feet resting on a firm surface. The patient's arm should be bare to the shoulder. The arm should be supported at heart level. The manometer should be at the eye level of the healthcare practitioner. A common error in taking blood pressure is the use of an improperly fitted cuff. Selection of an appropriately sized cuff requires assessment of the arm circumference. The midpoint position is determined by measuring the distance between the olecranon and acromion processes. The arm circumference is then measured at the midpoint. Once the arm circumference has been determined, the appropriate size cuff can be selected. Cuffs typically are marked with acceptable sizing indicators to facilitate proper fitting. However, it is more important to use a cuff that is appropriately sized for the arm. To assist in selecting the appropriate size, cuffs should be marked with an index line that runs perpendicular to the length of the cuff and a range line that runs parallel to the length of the cuff. The index line should fall within the range line when the cuff is secured to the upper arm. The cuff should be applied 2 centimeters above the crease of the elbow. It should fit snugly, but still allow 2 finger widths under the cuff. Next, find the brachial artery, which is palpable approximately 4 to 5 centimeters from the medial epicondyle on the anterior surface of the elbow. Place the stethoscope lightly against the skin over the brachial artery. There should be appropriate pressure to ensure good sound transmission. The stethoscope should not be in contact with clothing or with the cuff. Inflating the cuff to some arbitrary level runs the risk of excessive overinflation. To avoid this, determine the measurement of the pulse obliteration pressure. Rapidly inflate the cuff to 80 millimeters of mercury while palpating the radial artery pulse. Continue to inflate in 10 millimeter of mercury increments, taking note of the reading at which the pulse disappears. Then deflate the cuff at a rate of 2 millimeters of mercury per second, noting when the pulse reappears. Once the pulse obliteration pressure is determined, you are ready to measure the blood pressure. Inflate the cuff to a level 20 to 30 millimeters of mercury above the pulse obliteration pressure. Then, deflate the cuff at a rate of approximately 2 millimeters of mercury per second while listening for sounds. As the pressure in the cuff is decreased, blood flow in the brachial artery increases, creating turbulence, which generates Korotkoff sounds. Phase 1 sounds are clear, repetitive tapping sounds that coincide with reappearance of a palpable radial or brachial pulse. The onset of Phase 1 sounds are equivalent to the systolic blood pressure. Phase 2 sounds are audible murmurs in the tapping sounds. Phase 3 and 4 sounds are muted changes in the tapping sounds that occur as the pressure measurement approaches the diastolic pressure, usually within 10 millimeters of mercury of true diastolic pressure. Phase 5 sound is not really a sound, but rather is the level at which sounds disappear. Phase 5 indicates the diastolic blood pressure. To ensure that diastole has been reached, the cuff pressure should continue to be deflated for an additional 10 millimeters of mercury beyond the 5th Korotkoff sound. You should measure the blood pressure twice at a minimum, waiting at least 1 minute between readings. The average of the measurements should be recorded. In the following example, the patient's blood pressure is 116 over 90 millimeters of mercury. You will hear nothing until the first Korotkoff sound appears at 116 millimeters of mercury. The various phases of Korotkoff sounds will be heard until their disappearance at 90 millimeters of mercury. An auscultatory gap is defined as the intermittent disappearance of the initial Korotkoff sounds after their first appearance. This phenomenon can lead to underestimation of systolic blood pressure. Obtaining the pulse obliteration pressure can be helpful in avoiding incorrect measurement. In the following example, the systolic blood pressure will be heard at 162 millimeters of mercury, followed by an absence of sounds for 4 millimeters of mercury, after which they will reappear. Certain conditions may complicate blood pressure measurement or interpretation. In such settings, decreasing the rate of deflation and averaging several readings may improve accuracy. Observer bias is usually the most common error that occurs in blood pressure measurements. It occurs because practitioners often show digit preference and/or rounding of the terminal digit. When two people use the same correct technique for measuring blood pressure, there should be little inter-observer variation. Measuring blood pressure correctly is required to classify individuals, to stratify their cardiovascular risk, and to monitor the effects of treatment. This video provides the viewer with a standardized methodology that, when followed, will lead to accurate blood pressure measurement.
This is a video in clinical medicine from the New England Journal of Medicine.
Since pulse oximetry was introduced 3 decades ago as a monitoring tool, it has become ubiquitous in operating rooms, intensive care units, and hospital wards. Before pulse oximetry was available, physicians relied on invasive procedures, such as arterial blood gas analysis, to identify the presence of hypoxemia. Pulse oximetry has now become the standard of care in operating rooms and intensive care units in the United States and many other nations. Although the pulse oximeter is easy to use, the clinician must understand the principles of pulse oximetry and must know how the equipment works in order to interpret the information it provides. This video demonstrates the equipment needed and how to use it. It also addresses the common applications of pulse oximetry, explains how to interpret the data generated, and presents its limitations as well as common problems encountered with its use. Oxygen is present in two forms in the blood, dissolved and bound to hemoglobin. Hemoglobin can be functional or non-functional in terms of oxygen binding and transport. Functional hemoglobin binds and transports oxygen and is present as oxyhemoglobin and deoxyhemoglobin. Oxyhemoglobin contains bound oxygen, and deoxyhemoglobin is reduced hemoglobin without bound oxygen. Non-functional hemoglobin is unable to bind or transport oxygen and is present as carboxyhemoglobin and methemoglobin. Carboxyhemoglobin is hemoglobin bound to carbon monoxide. Methemoglobin is hemoglobin that contains ferric iron, Fe3+, an oxidized form of the oxygen-carrying ferrous iron, Fe2+, which is found in functional hemoglobin. The partial pressure of oxygen dissolved in arterial blood is termed PaO2. The percent saturation of oxygen bound to hemoglobin in arterial blood is termed SaO2. When measured by a pulse oximeter, SaO2 is termed SpO2. The hemoglobin-oxygen dissociation curve shows the relation between PaO2 and SaO2. The affinity of hemoglobin for oxygen varies at different partial pressures of oxygen, and although the relation is not linear, increases in PaO2 lead to higher SaO2. In general, 80% saturation corresponds to a PaO2 of 50 millimeters of mercury, and 90% saturation corresponds to a PaO2 of 60 millimeters of mercury. Pulse oximetry is indicated in all clinical settings where hypoxemia may occur, such as operating rooms, intensive care units, post-anesthesia care units, emergency departments and ambulances, endoscopy suites, sleep laboratories, cardiac catheterization laboratories, delivery suites, and wards. The use of pulse oximetry in these settings may reduce the need for arterial blood gas analyses and may guide clinical decision-making. There are no contraindications to pulse oximetry, and it is generally safe to use in monitoring all patients. Pulse oximeters consist of a peripheral probe and a small microprocessor unit. Traditionally, the peripheral probe contains a photodetector and two light-emitting diodes. The two light-emitting diodes emit light of different wavelengths. The light emitted by the diodes is absorbed by tissues, and the amount of absorption is determined by the photodetector. Using this information, the microprocessor determines the concentration of oxyhemoglobin and deoxyhemoglobin, respectively. It then calculates the percentage of oxyhemoglobin and displays the hemoglobin oxygen saturation in arterial blood, a waveform corresponding to the pulsatile flow in arterial vessels, and the heart rate. Pulse oximeters function on the principle that oxygenated and deoxygenated hemoglobin absorb red and infrared light differently. The light absorption of deoxyhemoglobin is greater at wavelengths of 600 to 800 nanometers, while the light absorption of oxyhemoglobin is greater at wavelengths of 800 to 1000 nanometers. One light-emitting diode emits light in the red spectrum at a wavelength of 660 nanometers, at which the light absorption of deoxyhemoglobin is greater than that of oxyhemoglobin. The other diode emits light in the infrared spectrum at a wavelength of 940 nanometers, at which oxyhemoglobin absorbs more light than deoxyhemoglobin. The microprocessor analyzes the light absorption of the tissues at each wavelength to determine the respective concentrations of oxyhemoglobin and deoxyhemoglobin. It then divides the concentration of oxyhemoglobin by the sum of the concentration of oxy and deoxyhemoglobin to determine the arterial blood oxygen saturation, SpO2. The probe is positioned so that the photodetector and light-emitting diodes face each other, with layers of tissue between them. The photodiodes turn on and off several hundred times per second to record the light absorption during pulsatile and non-pulsatile flow. During pulsatile flow, the light absorption of arterial blood, background tissues, and venous blood is detected. During non-pulsatile flow, only the light absorption of background tissues and venous blood is detected. The microprocessing unit compares the light absorption during pulsatile and non-pulsatile flow to isolate the light absorption of arterial blood and thus determine the arterial blood oxygen saturation. Pulse oximetry provides both qualitative and quantitative data. The qualitative data are obtained through the sounds emitted by the pulse oximeter. These sounds correlate with the level of oxygen saturation. A higher pitch indicates higher oxygen saturation, and a lower pitch warns of decreasing oxygen saturation. The pulse oximeter provides quantitative data through the display of a pulsatile waveform that corresponds to the flow of arterial blood. The numbers displayed indicate the hemoglobin oxygen saturation and the pulse. It is important to adhere to standard precautions before any contact with patients. Hand washing is the single most effective strategy to prevent the spread of infections. The ideal site for placement of the pulse oximeter probe is one that is well perfused, relatively immobile, comfortable for the patient, and easily accessible. The earlobes and the fingers are commonly used sites. Feet, cheeks, nose, and tongue may be used in cases of low peripheral perfusion. In adults, the probe can be placed on either side of the body. In newborns, however, placement on the right upper arm is preferable because of the possibility of a patent ductus arteriosus. Blood flowing to the right upper arm is the least diluted by the shunt and is therefore the most oxygenated. It is important to choose a probe that is the right size for the patient. If the probe is not the right size, the light-emitting diodes may not line up correctly with the photodetector and will provide inaccurate data. For example, a probe that is too large for a patient's finger may slip, and the light may not pass completely across the finger. Venous pulsations may occur if a probe is too small or is placed too tightly on the finger. These venous pulsations will produce interference, resulting in a falsely low pulse oximeter reading. Pulse oximeter probes with adhesive sensors may minimize motion and may yield more accurate results than non-adhesive sensors. Even though it is easy to use, the pulse oximeter can produce erroneous data in certain circumstances. One common problem is the occurrence of movement artifacts when there is movement at the site where the probe is placed. This may interfere with proper function and most often occurs if a patient is shivering, has seizures, or is being transported by ambulance or helicopter. The waveform of the pulse oximeter will be distorted in such circumstances, and the clinician should recognize that the measurement displayed is inaccurate. A bright light, such as an operating room lamp, may cause light interference, leading to an erroneous reading. Electromagnetic radiation, such as that emitted from an MRI scanner, may also interfere with pulse oximetry. If the probe is poorly placed or is the wrong size, light from only one light-emitting diode may pass through the tissues, or the light may not reach the detectors. This will result in falsely elevated or depressed results. Nail polish that absorbs light at 660 nanometers or 940 nanometers may also interfere with the pulse oximeter and result in an inaccurate reading. This problem can be avoided by removing the nail polish. The presence of intravascular dyes such as methylene blue or indigo carmine may alter the red and infrared light absorption properties of the blood and tissues, also resulting in an inaccurate reading. Non-functional hemoglobin can also result in inaccurate pulse oximeter data. At 940 nanometers, the light absorption of carboxyhemoglobin is minimal and does not affect the SpO2. However, at 660 nanometers, the light absorption of carboxyhemoglobin is similar to that of oxyhemoglobin. The pulse oximeter cannot differentiate between oxyhemoglobin and carboxyhemoglobin in this instance, and may erroneously display a normal or near normal arterial blood oxygen saturation when the actual arterial blood oxygen saturation may be low. At 940 nanometers, methemoglobin absorbs more light than either deoxyhemoglobin or oxyhemoglobin. At 660 nanometers, the light absorption of methemoglobin is similar to that of deoxyhemoglobin. In this instance, the pulse oximeter cannot differentiate between methemoglobin and deoxyhemoglobin and may incorrectly detect an elevated deoxyhemoglobin concentration, resulting in a falsely low interpretation of arterial blood oxygen saturation. Carboxyhemoglobin may cause a falsely high SpO2, whereas methemoglobin may cause a falsely high or falsely low reading, depending on the actual concentration of oxyhemoglobin. Newer pulse oximeters are able to emit light at up to 8 different wavelengths. This increase in the number of available wavelengths makes it possible for the oximeter to distinguish carboxyhemoglobin and methemoglobin. There are additional limitations. Peripheral vasoconstriction, hypoperfusion, hypothermia, shock, and anemia may also yield inaccurate results. If you do not get a reading from the pulse oximeter, either when you attach it to the patient or during use, there is a series of steps you can follow to determine the problem. First, make sure the probe has not fallen off the placement site. If it has been displaced, adjust the probe as necessary. If not, make sure the cable connecting the probe to the microprocessor is intact and is in fact connected to the microprocessor. The cable may become loose or detached, making it seem as though the pulse oximeter cannot determine the arterial blood oxygen saturation. If the cable is loose, adjust the connection as necessary. Next, make sure the red light on the inside of the probe is evident. If you do not see the red light, check the power cable. If you can see the red light and have made sure the cable connecting the probe to the microprocessor is intact, clean the probe and place it on your finger to see whether the issue is specific to the patient. If this is not the case, it is possible that either the probe or the microprocessor is not working properly. Replace the probe, the microprocessor, or both as necessary. Although the pulse oximeter is generally a safe device, its use still carries some risk of adverse events. Ischemic pressure necrosis may result if the probe is placed too tightly on the patient. Perioperative corneal abrasion may occur if a patient with a probe on a finger rubs his or her eyes when awakening from anesthesia and in doing so scrapes the cornea. Prolonged placement of a pulse oximeter probe, as may occur in patients in the ICU, may lead to mechanical injury, such as finger stiffness, making it difficult to flex the finger after removal of the probe. Although previously documented, these complications remain uncommon. If used correctly, pulse oximetry is a potentially life-saving tool. Healthcare providers need to be aware of the indications, benefits, and disadvantages of pulse oximetry. Most important, clinicians must be able to interpret the information pulse oximetry provides. With proper training and instruction, pulse oximetry is an invaluable monitoring tool.
This is a video in clinical medicine from the New England Journal of Medicine.
Radial arterial puncture for arterial blood gas analysis is a common procedure performed in medicine. It is a fundamental skill that all medical trainees need to acquire. This video will review radial arterial puncture in the adult population. Puncture of the radial artery is the preferred method of obtaining an arterial blood sample for blood gas analysis. The chief indication for measurement of arterial blood gas level is to obtain values for the partial pressures of oxygen and carbon dioxide, and for arterial pH. This information is needed when assessing a patient with acute severe respiratory distress. Measurements of arterial pH and the partial pressures of carbon dioxide and oxygen provide accurate information on the status of acid-base balance and gas exchange. Another indication for arterial blood gas analysis is co-oximetry in order to assess for methemoglobinemia and carboxyhemoglobin. Radial arterial puncture is contraindicated in the presence of a known deficiency of collateral circulation to the distal upper extremity. Some physicians advocate for the use of the modified Allen test to assess the adequacy of collateral circulation of the radial artery by the ulnar artery. The Allen test is controversial, however, in that its ability to predict the risk of rare ischemic complications accurately is limited. Thus, based on current evidence, its use can be neither refuted nor supported. To perform the Allen test, occlude both the ulnar and radial arteries. Instruct the patient to make a fist to drain the blood from the hand. This should be done for approximately 30 seconds. Instruct the patient to unclench the fist. The patient's palm should appear blanched or pale. Now release pressure only from the ulnar artery. Adequate collateral circulation is indicated by the return of normal color within 10 seconds. Alternative techniques that can be used to measure collateral circulation of the forearm include color Doppler flow study, plethysmography, and MRI. These methods are more often used when assessing the radial artery for more invasive procedures, such as arterial harvesting for coronary bypass. In addition, radial arterial puncture should not be performed in the presence of an overlying skin infection. It is relatively contraindicated in patients receiving anticoagulants or in those with coagulopathies because of the increased risk of bleeding and hematoma formation. Standard arterial blood gas sampling kits are readily available that contain a syringe, a small 23 to 25 gauge needle either with a rubber stopper that may be used to remove the needle from the syringe or with an attached safety cap, and a syringe cap containing dry lithium heparin or sodium heparin. The concentration of heparin here varies depending on the manufacturer of the kit. You will also need the following: alcohol swabs, sterile pieces of gauze, tape, non-sterile gloves and a non-sterile gown, 1% lidocaine without epinephrine for local analgesia, a 5 cc syringe with a 25 gauge needle, a small rolled towel to place under the wrist, and a bag of ice in which to transport the sample to the lab, if required. Arterial blood gas sampling often takes place in an emergency setting and may not allow for obtaining consent from the patient or next of kin. When possible, the procedure should be explained to the patient and consent obtained. Wash your hands according to good standards prior to examining the patient. Extend the patient's wrist to bring the radial artery close to a more superficial position. The radial artery is located between the styloid process of the radius and the flexor carpi radialis tendon. First, palpate the styloid process of the radius. Next, palpate the flexor carpi radialis tendon located medial to the styloid process of the radius. Now locate the artery between these 2 points. The artery may be difficult to palpate, for example, in the presence of overlying edema or vasospasm. A portable Doppler ultrasound device may be used to identify the location of the radial artery in these instances. Extend the patient's wrist and place a rolled towel under it to maintain it in an extended position. Once the patient's wrist is positioned, put on a non-sterile gown and non-sterile gloves. Open the arterial blood gas kit and identify all the components so they are ready for use. Clean the site with an alcohol swab. Palpate the radial pulse and determine the point of maximum impulse, or use the Doppler ultrasound device to identify the location of the radial artery. Using the 5 cc syringe and small needle, draw up 1% lidocaine. Upon introducing the needle under the skin, draw back on the plunger to ensure that you have not punctured a vessel. Inject a small wheal of analgesic around the artery and wait 30 to 60 seconds for the lidocaine to take effect. Again, locate the maximum impulse with the index and middle fingers of the non-dominant hand. Holding the arterial blood gas syringe with the dominant hand, aim the needle away from the hand and toward the upper arm, and puncture the skin at a 30 to 45 degree angle at a point just below the index and middle fingers of the non-dominant hand. Advance the needle slowly until the syringe easily and passively fills with bright red pulsating blood. Ideally, you should obtain at least 1 to 2 cc's of blood. If no blood is obtained, do not pull back on the plunger. Withdraw the needle slowly until it is just under the skin and reattempt the procedure. After the blood sample is collected, withdraw the syringe and have an assistant apply pressure to the site with sterile gauze for approximately 5 minutes. In the meantime, expel the air bubbles from the syringe. Cover the needle with the attached safety cap and remove the needle from the syringe. Or remove the needle from the syringe using the rubber stopper. Attach the heparin-containing cap and, while holding the cap in place, push the plunger of the syringe to ensure the blood encounters the heparin. This will prevent the blood from clotting. Ensure that the syringe is labeled with the patient's name and unit number. Place the entire syringe in the bag of ice if transport to the lab is required. After pressure has been applied to the puncture site for 5 minutes, affix the gauze with some tape. Dispose of all sharps in the designated sharps containers. The most common technical difficulty associated with radial arterial puncture for arterial blood gas analysis is failure to obtain a blood sample because of vasospasm, or obtaining venous instead of arterial blood. If vasospasm is suspected, abort the procedure and reattempt it on the other wrist. A blood sample is likely to be venous if it is non-pulsatile and dark in color and it flows slowly. It should be noted, however, that very deoxygenated blood in a patient with hypoxemia could also appear dark, even though it is arterial. Serious vascular complications of radial arterial puncture are rare and include radial arterial aneurysm, hand ischemia, and hematoma causing compartment syndrome. Arterial blood gas analysis provides useful information regarding respiratory and metabolic pathology. The partial pressure of carbon dioxide, bicarbonate concentrations, and pH values will assist in diagnosing the presence of primary or mixed respiratory and metabolic acidoses or alkaloses. The partial pressure of oxygen will reveal abnormalities in blood oxygen content and the presence of hypoxemia. With the appropriate technique, radial arterial puncture for arterial blood gas analysis is a skill easily mastered by medical trainees. A more detailed approach to acid-base disorders and hypoxemic respiratory failure, while necessary, is beyond the scope of this instructional video.
This is a video in clinical medicine from the New England Journal of Medicine.
Overview. Carbon dioxide is generated in the body as a metabolic byproduct. Carbon dioxide dissolves in the blood and is transported in the bloodstream until it reaches the lungs, where it diffuses into the alveoli. The alveoli are ventilated through an open tracheobronchial tree and a patent upper airway. Carbon dioxide can then be detected in the patient's expired breath. The measurement of expired carbon dioxide provides insight into important life-sustaining processes that include metabolic, circulatory, and respiratory activity. Capnography is the standard of care for monitoring the adequacy of ventilation in patients receiving general anesthesia. It is also used to monitor ventilation during procedures performed while the patient is under moderate or deep sedation. Capnography is increasingly being used to monitor patients who are receiving mechanical ventilation in intensive care units and to aid in the assessment and treatment of cardiac arrests. Before capnography was available, physicians relied on the physical exam, such as auscultation of the chest, to assess the adequacy of ventilation and proper placement of endotracheal tubes, and on arterial blood gas analysis to determine the partial pressure of carbon dioxide. Capnography allows for non-invasive and continuous monitoring of carbon dioxide levels and can provide valuable information regarding the metabolic, circulatory, and respiratory conditions of a patient. Although capnography is not complicated, the clinician must understand the principles of capnography and how the equipment works in order to interpret the information it provides. Definitions. Capnometry refers to the measurement and numerical display of carbon dioxide concentrations. Capnography refers to the graphic display of the exhaled and inhaled carbon dioxide concentration plotted against time. Colorimetric capnography is a qualitative method of determining the presence of carbon dioxide using a pH-sensitive filter that changes color from purple to yellow when carbon dioxide is detected. PaCO2 denotes the partial pressure of carbon dioxide in arterial blood. End-tidal carbon dioxide is the percentage concentration or partial pressure of carbon dioxide at the end of exhalation, normally 5% of atmospheric pressure or approximately 38 millimeters of mercury at sea level. Hypercapnia and hypercarbia refer to a greater than normal partial pressure of carbon dioxide in blood. Hypocapnia and hypocarbia refer to a lower than normal partial pressure. Indications. Capnography is used in the operating room to aid in the proper placement of endotracheal tubes and to monitor ventilation. Capnography is increasingly being used to assess the adequacy of ventilation and to monitor for hypercapnia or hypocapnia in treatment areas such as intensive care units, post-anesthesia care units, emergency departments and ambulances, endoscopy suites, sleep laboratories, and cardiac catheterization laboratories. Carbon dioxide detection is frequently used during cardiopulmonary resuscitation to aid in determining the proper placement of an endotracheal tube and to assess the effectiveness of resuscitation efforts. While pulse oximetry is a good method for the assessment of oxygenation, capnography provides more direct information on a patient's ventilatory status. Capnography is particularly helpful in patients who are receiving supplemental oxygen, during which a normal hemoglobin oxygen saturation can be present in spite of marked hypoventilation. Contraindications. There are no contraindications to the use of capnography, provided that the data obtained are evaluated in the context of the patient's clinical circumstances. It is generally safe to use capnography for the monitoring of all patients. Principles of operation. Capnography is based on the concentration of carbon dioxide in a sample of exhale gas throughout the respiratory cycle. Because of the chemical properties of carbon dioxide, a variety of techniques can be used to measure its concentration. Infrared absorption spectroscopy is typically used in clinical practice. Infrared light can be passed through a sample of gas to an infrared detector. As the concentration of carbon dioxide increases, the intensity of the light that reaches the detector decreases. Carbon dioxide gas strongly absorbs infrared light with a wavelength of 4.3 microns. At this wavelength, there is minimal interference from other gases that may also be present, such as water vapor, oxygen, nitrous oxide, and inhaled anesthetic agents. There are two types of capnograph devices. Mainstream capnographs use sensors that are placed directly into the breathing circuit of a ventilator. Side-stream capnographs draw a sample of gas away from the breathing circuit to a separate gas sensor. The response of a side-stream device to changes in carbon dioxide concentration is delayed by a few seconds, since the gas must travel through the sampling line before it can be analyzed. However, in patients who are not intubated, side-stream capnographs can be used conveniently with a face mask or nasal cannula to monitor respiration. Nasal cannulas and face masks that feature integrated CO2 sampling are commercially available. You can modify standard face masks by attaching the sampling line directly to the orifice of a mask, or by securing the sampling line inside the mask. Take care that the orifice does not rest against the patient's skin to avoid occlusion of the flow of gas into the sampling line. Alternatively, you can place an integrated sampling nasal cannula underneath a face mask. Data interpretation. A normal capnogram shows a regular, nearly square waveform that oscillates at the same frequency as the patient's respiratory rate. During inspiration, the capnogram should be at 0 as the patient breathes in fresh gas. When the patient starts to exhale, the first gas exhaled will be from the anatomical dead space and will contain little or no carbon dioxide. However, the concentration of carbon dioxide in the exhale gas will rise rapidly and plateau as the alveoli begin to empty. As exhalation proceeds, the concentration of carbon dioxide remains high and increases slightly. The peak concentration reached at the end of exhalation is the EtCO2. As the patient begins to inhale again, the capnogram falls rapidly to 0, indicating the absence of carbon dioxide in the inspired gas. In patients who are not intubated, the samples of the exhale gas are mixed with the surrounding atmosphere and fresh gas flow, diluting the concentration of carbon dioxide. As the side stream catheter is moved farther away from the patient's airway, the EtCO2 value will decrease progressively. Although the EtCO2 of a patient who is not intubated represents only a qualitative indicator of ventilatory status, the patient's respiratory rate can still be determined from the waveform of the capnogram. Proper use of capnography. In patients who are not intubated, place the side stream sampling catheter close to the patient's airway, using either a face mask or a nasal cannula. Capnography should be started before treatment is begun so that satisfactory baseline tracings of the patient's spontaneous respiration can be obtained and correct operation of the capnograph can be confirmed before any procedural sedation is administered. Any change in respiration can then be assessed relative to this baseline. In patients undergoing endotracheal intubation, capnography helps to show that the trachea, and not the esophagus, has been successfully intubated. However, if the stomach is insufflated with air that contains carbon dioxide, or if the patient has recently swallowed a carbonated beverage, the capnogram might transiently show the presence of carbon dioxide, even if the endotracheal tube has been erroneously placed in the esophagus. A series of successive, steady, normal capnographic waveforms must be seen to rule out esophageal intubation. In addition, a capnogram tracing indicates gas exchange and does not inform the clinician about whether the endotracheal tube is positioned properly. For example, whether it is in a bronchus or in the oropharynx. Capnography is useful for the measurement of the ventilatory characteristics of intubated patients, and it may reduce the need to measure arterial blood gas. Common problems and limitations. Capnography is valuable for monitoring a patient's respiratory status. However, it is important to be aware of circumstances that may affect its reliability and to be able to recognize and interpret abnormal waveforms that may result from pathologic features or from technical difficulties. Capnograms must always be interpreted in conjunction with other physiological variables, and clinical judgment is important. Loss of the capnographic waveform may be caused by apnea, disconnection of a ventilator circuit, occlusion or dislodgement of an endotracheal tube, or occlusion or disconnection of the sampling line. Waveforms that do not return to zero during inspiration indicate rebreathing of carbon dioxide. This can occur if the carbon dioxide absorber in an anesthesia machine is chemically exhausted, if a valve in the ventilator circuit is not functioning properly, or if the flow of fresh gas is insufficient. An elevated baseline can also be seen if the device is calibrated incorrectly. Decreases in EtCO2 can be due to hyperventilation, pulmonary embolism, cardiac arrest, sudden hypotension, hypovolemia, hypothermia, leaks in the sampling system, or a partial airway obstruction. Increases in EtCO2 can result from hypoventilation, rising body temperature, bronchospasm, adrenergic discharge, release of a tourniquet on an extremity, or ventilation of a previously unventilated lung. Shallow breathing transiently lowers EtCO2 because of dead space ventilation, but EtCO2 rises again when full gas exchange occurs. Cardiac oscillations result from the transmission of cardiac movements to the lungs and airways. These oscillations are usually seen when either respiration is slow or the tidal volume is small. Such oscillations suggest inadequate ventilation, and a capnogram with prominent cardiac oscillations suggests the need to initiate assisted or mechanical ventilation. Although capnography provides a quantitative measurement of EtCO2, it is not as accurate as blood gas analysis for the assessment of the partial pressure of arterial carbon dioxide. A gradient exists between the partial pressure of arterial carbon dioxide and EtCO2. This gradient increases as the dead space volume increases. In disease states characterized by increased dead space and ventilation-perfusion mismatch, such as emphysema, an arterial blood gas analysis is necessary for an accurate determination of the partial pressure of arterial carbon dioxide. Troubleshooting. Artifacts should be the last explanation for changes in critical values. Therefore, when a low or high carbon dioxide reading is obtained, a physical assessment of the patient must be performed before the assumption is made that the values represent equipment malfunction. If the patient appears to be clinically stable, consider the possibility of either leakage or occlusion of the sampling system. Make sure that the side stream sampling line is well connected to the circuit and to the water trap on the capnograph, and that the water trap is firmly attached to the capnograph. To quickly test the integrity of the sampling line and monitor, breathe into the sampling line. A waveform confirms proper sampling, although small leaks diluting the sampled gas may go unnoticed. The sampling line or water trap may become occluded with condensed water. Disconnecting the sampling line and flushing it with air from a syringe can sometimes clear it, but it may be necessary to replace these components. Elevating the side stream sampling line above the ventilator circuit helps prevent the entry of condensed water. A humidity barrier is also useful, although this will increase the response time of the capnogram. Complications. Although capnography is generally safe, its use still carries a small risk of adverse events. Mainstream analyzers may introduce an excessive amount of dead space into the ventilator circuit. Older generation mainstream sensors use heat to inhibit the condensation of water vapor and prevent falsely high carbon dioxide readings. But this increases the risk of burning the patient's skin. Also, to reduce the risk of accidental extubation, caution must be taken to minimize the amount of additional weight placed on the airway. Summary. When used correctly, capnography is a potentially life-saving tool. Healthcare providers need to be aware of the indications, benefits, and disadvantages of capnography and must be able to interpret the information it provides. With proper training and instruction, clinicians will find capnography to be an invaluable tool for monitoring ventilation.
This is a video in clinical medicine from the New England Journal of Medicine.
This video will demonstrate the placement of the laryngeal mask airway, or LMA, as an emergency airway device in patients experiencing a cardiopulmonary arrest. The goal is to provide familiarity with and instruction in its use so that a clinician will be comfortable using this device to provide effective ventilation for patients in cardiopulmonary arrest. Instruction beyond this video is necessary for safe and effective placement of a laryngeal mask airway, and the clinician should seek further training from anesthesiologists or others who have expertise in its use. The laryngeal mask airway is a device used routinely by anesthesiologists for surgical operations. Its use should also be strongly considered for ventilation in pre-hospital and in-hospital cardiac arrests. Both the American Heart Association and the European Resuscitation Council consider the laryngeal mask airway an acceptable device for use by non-experts in tracheal intubation when performing emergency airway management. The laryngeal mask airway is also an important rescue device in situations where tracheal intubation is impossible or has failed, and in situations where access to the head or positioning for intubation is not possible. Use of laryngeal mask airway instead of bag and mask ventilation during CPR has also led to fewer events of pulmonary aspiration during resuscitation. The reasons for laryngeal mask airway placement during CPR are many and include high first-time success rates, rapid placement by both novices and experts, necessitating minimal disruption, if any, of chest compressions, ease of ventilation during prolonged resuscitations as compared with bag and mask ventilation. It is a good option over placing an endotracheal tube when tracheal intubation is difficult or has failed, and placement can be achieved without head movement in patients with potential instability of the cervical spine, for example in patients with traumatic injuries or rheumatoid arthritis. An adult-sized laryngeal mask airway is a flexible breathing tube of approximately 25 centimeters in length with an inflatable bladder or cuff on its distal end. proximal end has a standard 15 mm connector that allows attachment to any ventilation system. Air exchange occurs through the aperture on the distal end of the tube. This illustration shows the identity and location of the tongue, hard palate, epiglottis, esophagus, and laryngeal inlet. Review of these structures is helpful for understanding proper placement and potential difficulties. Unlike oral airways and nasal airways, the laryngeal mask airway bypasses all pharyngeal structures to provide a more direct conduit to the laryngeal inlet. When properly placed, the laryngeal mask airway requires less pressure than bag and mask ventilation to achieve effective ventilation, thus minimizing the risk of gastric insufflation and subsequent pulmonary aspiration. Current laryngeal mask airway models include both straight and pre-curved tube designs and models intended for either single or multiple uses. Some devices include a separate channel for suctioning the stomach, while others are specifically designed to facilitate oral tracheal intubation through the device. Laryngeal mask airways are available in up to 5 pediatric sizes and 3 adult sizes. Typically, your resuscitation committee will decide upon a model and sizes suitable to your patient population. As a general rule, a number 4 laryngeal mask airway is adequate for the average adult female patient and a 5 for the average adult male patient. You'll need to consult the sizing chart provided by the manufacturer of the device to select the correct size. To prepare for laryngeal mask airway insertion, you'll need an appropriate size device, a 20 to 40 milliliter syringe, lubricating jelly, and tape. Often, laryngeal mask airways come pre-packaged with an inflation syringe and a small package of lubricant. Prepare the device by first removing all excess air from the bladder. Then lubricate the posterior surface of the cuff to facilitate easy and smooth passage into the mouth. The posterior surface is the side opposite where air exchange occurs. The following sequences will demonstrate the placement of laryngeal mask airway in consenting adults undergoing elective surgical operations. With the patient in the supine position, gently tilt the head backwards to facilitate placement. Do not perform this backwards tilt in an unconscious patient in whom a neck injury is suspected. Place a straight laryngeal mask airway, open the mouth as fully as possible, and insert the device into the mouth, directing the posterior cuff against the hard palate. Continue with this motion until you feel the tube's cuff pass behind the tongue completely, and then until you meet resistance. Successful insertion depends on keeping the leading edge flat to prevent the cuff from folding on itself and exerting firm pressure against the hard palate during passage. Inflate the cuff with approximately 30 milliliters of air. During inflation, the shaft of the airway often moves out of the mouth 1 to 2 centimeters as it finds its proper location. The cuff should not be visible when the tube is in the proper position. The final resting position is posterior to the tongue at the laryngeal inlet, as shown in this illustration and in this fiber optic view through the distal end of the device. This cutaway view of the head and neck illustrates the path taken by the laryngeal mask airway during insertion and where it rests following insertion. Key structures are labeled to illustrate the relevant anatomy. Use of a pre-curved laryngeal mask airway sometimes allows placement without the need to insert hands inside a patient's mouth. To place a pre-curved laryngeal mask airway, grab the connecting tube with your dominant hand so the cuff points to the patient's head. Your hand should be in a neutral position with the thumb on the upward surface of the tube. As with the straight tube, guide the laryngeal mask airway above and behind the tongue by applying firm pressure along the patient's hard palate. Guide the tube behind the tongue and toward the larynx with a circular motion of the hand. After placement, inflate the cuff and then connect the device to a positive pressure ventilation system. Confirm proper placement by auscultation of breath sounds. Auscultation of breath sounds should take less than 5 seconds, and placement of the laryngeal mask airway during resuscitation should not require interruption of CPR. Improper placement of the laryngeal mask airway can result in a poor seal or an obstruction of airflow. If air leaks from the mouth or you do not achieve adequate ventilation, add an additional 5 to 10 milliliters of air to the cuff. If additional air in the cuff fails to improve ventilation or decrease the air leak, then gently remove and reinsert the laryngeal mask airway. If ventilation is still not achieved or there is still a large leak of air from the mouth, attempt placement of a larger laryngeal mask airway. The most common location of obstruction is at the level of the oropharynx, either because the epiglottis has folded down or because the tongue or redundant oropharyngeal tissue is pushed into the airway. Selection of the proper size laryngeal mask airway, as well as use of proper insertion technique, will reduce the frequency of these problems. Use of a tongue blade to partially retract the tongue and to provide counterpressure against the hard palate is one way to improve entry of the laryngeal mask airway into the mouth. Additional lubrication or briefly dipping the cuff in clean water may also help prevent the cuff from sticking to the tongue and oropharynx. In addition, a small mouth opening or large tongue may prevent use of the operator's finger and hand to get the laryngeal mask airway behind the tongue. In such cases, use of the connecting tube shaft to create downward pressure may be necessary. Once adequate ventilation has been established, secure the laryngeal mask airway with tape to prevent movement of the device. Even when secured, the laryngeal mask airway may become dislodged with motions such as twisting or pulling. When moving patients, place one hand at the base of the laryngeal mask airway and disconnect the ventilation system from the device. Once the laryngeal mask airway is placed, the adult patient should receive 8 to 10 breaths per minute during continuous chest compressions. You should deliver quick breaths, ideally less than 1 second per breath, each with a volume of approximately 500 milliliters. If you hear air leakage during ventilation, you'll have to alternate ventilation and chest compressions. In the latter case, give 2 500 milliliter breaths following every 30 chest compressions. This ratio of 30 compressions to 2 breaths should be continued for as long as CPR is being performed. Delivery of drugs through the laryngeal mask airway to the pulmonary epithelium is unreliable and is not recommended. The laryngeal mask airway may be left in place for the duration of the resuscitation. If a definitive airway is still needed, an experienced provider in airway management should replace the laryngeal mask airway with an endotracheal tube. Complications associated with laryngeal mask airway use are similar to those with other tools used for airway management. However, there may be fewer complications than with bag and mask ventilation and endotracheal intubation. These complications include the potential for upper airway trauma, tooth dislodgement or damage, and the introduction of a large volume of air into the stomach. Despite its numerous advantages for rescue ventilation, the laryngeal mask airway does not provide a secure airway and will not protect against aspiration when the volume of gastric contents is large. It may also be difficult to ventilate a patient with a laryngeal mask airway when high airway or thoracic pressures are encountered, for example during vigorous chest compressions, or in obese patients, or patients with parenchymal lung disease. Additional familiarity with the laryngeal mask airway can be gained with practice on a training head model, on a patient simulator, or on real patients in the operating room under the guidance of an anesthesiologist. The laryngeal mask airway provides a fast and effective alternative to tracheal intubation and is used for an increasing number of clinical indications, including ventilation during cardiopulmonary arrest. Laryngeal mask airway placement is usually successful in the initial attempt. Thus, it is an important procedure to learn and practice.
This is a video in clinical medicine from the New England Journal of Medicine.
Common indications for nasogastric intubation include decompression of the GI tract in patients with bowel obstruction and gastric emptying in intubated patients to prevent aspiration. NG tubes may be placed as an adjunct for the delivery of oral agents such as activated charcoal or oral radiographic contrast media. NG tubes are often placed in patients with suspected upper GI hemorrhage. However, The sensitivity and negative predictive value of nasogastric aspirates for detecting active bleeding is suboptimal, and the absence of bloody return cannot be relied upon to rule out hemorrhage. Nonetheless, nasogastric intubation may be useful in selected patients. Evacuation of blood and clots from the stomach may facilitate the endoscopic visualization of the gastric and duodenal mucosa, and the return of bright red blood does provide prognostic information. Nasogastric intubation and gastric emptying may be beneficial in patients with severe pancreatitis and associated ileus. However, it has been shown that NG tubes are not beneficial and, in some cases, detrimental in patients with mild or moderate symptoms. Nasogastric intubation should be avoided in patients with significant maxillofacial trauma, as the tube may enter the cranial vault if the thin cribiform plate has been disrupted. The procedure should also be avoided in patients with known esophageal abnormalities such as recent caustic ingestion, diverticulae, or strictures, as they are at high risk for esophageal perforation. Since nasogastric intubation may induce emesis, patients who are unable to adequately protect their airway should be intubated with a cuffed endotracheal tube if the procedure must be performed. Begin by gathering equipment you will need. This will include gloves, a protective gown, and face shield, an appropriately sized nasogastric tube, vasoconstrictor spray, and a topical anesthetic such as benzocaine or lidocaine solution with an atomizer. Obtain a lubricant, a glass of water with a straw, towels or blue pads, a 60 cc catheter tip Toumi syringe, a stethoscope for tube confirmation, tape, and a wall suction setup. Have the patient breathe in through each nostril to assess which side is more patent. Premedicate the nasal cavity with a vasoconstricting spray such as phenylephrine or oxymetazoline. Anesthetize the nasal cavity with a topical anesthetic such as 4% lidocaine or topical lidocaine jelly. The posterior oropharynx should also be anesthetized with lidocaine or topical benzocaine spray. Nebulized lidocaine may also be used. The proper depth of tube insertion is approximated by measuring the distance from the xiphoid process to the angle of the mandible and then to the nostril. Lubricate the distal tip of the nasogastric tube with surgical jelly or viscous lidocaine. Position the patient sitting upright in the sniffing position. Insert the tip of the nasogastric tube into the nasal cavity and slowly advance it posteriorly, parallel to the floor of the nasal canal. The tube should not be directed upwards. In this endoscopic view of the nasal cavity, note that if the tube is passed in an upwards fashion, it will reach a blind recess at the middle turbinate. When the tube is passed parallel to the nasal floor, it reaches the posterior nasopharynx without difficulty. Continue to pass the tube posteriorly. The patient may gag once the tube reaches the larynx. Temporarily halt the advancement of the tube and ask the patient to begin swallowing sips of water through a straw. Coordinating advancement of the tube with the swallowing mechanism facilitates passage of the NG tube into the esophagus and prevents entry into the trachea. This is a fluoroscopic view of a nasogastric tube being inserted. As the tube reaches the level of the larynx, advancement is temporarily halted. The tube is then inserted as the patient swallows, and once past the larynx, is rapidly advanced. Note that in this endoscopic view of the larynx, the trachea is frequently open and may be accidentally intubated with an NG tube. Note also that as the patient swallows, the laryngeal apparatus arises and the epiglottis covers the glottis, preventing tracheal entry. Once past the larynx, the tube may be inserted rapidly to the predetermined depth. Check the black markings on the tube to confirm proper depth of insertion. Assure that the patient is in no respiratory distress and is able to speak. If the patient is unable to talk, is in respiratory distress, or if respirations can be heard through the tube, it should be removed immediately, as tracheal intubation has likely occurred. Attach the catheter tip syringe to the main port of the NG tube and insufflate 30 cc of air while auscultating over the epigastrium. A gurgling noise should be clearly audible. Using the same syringe, Aspirate the NG tube and ensure that it fills with gastric contents. It should be noted that auscultation and aspiration may occasionally provide false positive results. Therefore, radiographic confirmation of tube placement by visualizing the NG tube's descent below the diaphragm should be obtained prior to infusion of any substance, such as activated charcoal or oral contrast media. The tube should be secured to the patient prior to transport to the radiology suite. Take a 5 to 7 centimeter strip of adhesive tape and tear it vertically for 1/2 of its length. The wide section is placed across the patient's nose, and the two tails are then wrapped in opposite directions around the NG tube. You may now connect the nasogastric tube to suction. Turn on the suction and adjust the vacuum force as desired. Minor complications of NG tube insertion include epistaxis, sinusitis, and sore throat. More serious sequelae include esophageal perforation, pneumothorax, aspiration, and, rarely, intracranial placement.
This is a video in clinical medicine from the New England Journal of Medicine.
Urethral catheterization may be performed as either a therapeutic or a diagnostic procedure. Therapeutically, catheters may be placed to decompress the bladder in patients with acute or chronic urinary retention. In addition, catheters may be placed to facilitate bladder irrigation in patients with gross hematuria. Diagnostically, urinary catheters may be placed to obtain an uncontaminated urine sample for microbiologic testing, to measure urinary output in critically ill patients or during surgical procedures, or to measure post-void residuals. The only absolute contraindication to urethral catheterization is known or suspected urethral injury, usually in the setting of a pelvic fracture. Trauma patients presenting with blood at the urethral meatus or with gross hematuria, perineal hematoma, or a high-riding prostate gland should be evaluated with retrograde urethroplasty before catheterization. Relative contraindications to catheterization include urethral stricture, recent urethral or bladder surgery, and a combative or uncooperative patient. Most of the equipment required for urinary catheterization can often be found in a prepackaged catheterization tray. The contents of a typical tray include sterile drapes and gloves, an antiseptic solution such as povidone iodine or chlorhexidine, and cotton balls and forceps for application of antiseptic. Kits also include a Foley catheter, a sterile lubricant, a syringe with water for balloon inflation, and a sterile drainage bag. Additional equipment that is not included in the standard tray includes viscous lidocaine and tape or another device to secure the catheter to the patient. There are many different types and sizes of urinary catheters available. The Foley catheter, a double-lumen urethral catheter with a straight tip, is most frequently used. One lumen is dedicated to urinary drainage, and the second is used to inflate the retention balloon at the distal end of the catheter. A 16 to 18 French is the appropriate size for most adult patients. Larger catheters, 22 to 24 French, should be used for patients with gross hematuria in order to prevent clots from obstructing the lumen. The Coudet catheter has a semi-rigid, curved tip that facilitates catheterization in men with prostatic enlargement. Triple lumen catheters, which have an additional port for bladder irrigation, are often used in patients with gross hematuria or clots. The average male urethra is approximately 20 centimeters long and takes an S-shaped course through the penis, urogenital diaphragm, and prostate gland. Note that downward traction on the penis exaggerates this curvature, making catheterization difficult. When the penis is held taut and perpendicular to the body, the urethra straightens, facilitating the procedure. Carefully inspect and prepare all equipment before beginning the catheterization. Sterile gloves should be worn when equipment is handled and while the procedure is carried out. Arrange the contents of the catheterization tray on a bedside table. Check the integrity of the retention balloon and securely attach the catheter to the collection tubing on the drainage bag. Finally, pour the antiseptic solution onto the cotton balls and lubricate the distal tip of the catheter. Place the patient in a supine position on the stretcher. The foreskin should be fully retracted in uncircumcised patients. Next, inject 10 to 15 milliliters of viscous lidocaine into the urethra. This not only anesthetizes the mucosa, but also distends the urethra, facilitating catheterization. Firmly pinch the end of the penis for several minutes to retain the lidocaine within the urethra. Place the sterile drape over the patient's thighs and the fenestrated drape over the pubic region. Grasp the shaft of the penis with your non-dominant hand. This hand is now considered to be non-sterile, and it should not let go of the penis or touch any sterile equipment throughout the remainder of the procedure. Cleanse the glands in a circular motion using the forceps and antiseptic-soaked cotton balls. It is helpful to place the box from the catheter kit on the patient's thighs before the catheter is placed. During insertion, the penis is held upright, perpendicular to the plane of the body. In this demonstration, a Coudet catheter is being used. When using a Coudet, be sure that the tip of the curved catheter is pointing upward in the 12 o'clock position. Place the tip of the catheter into the meatus and advance it slowly and gently through the urethra. Never force the catheter, since this may create a false passage or other urethral trauma. Continue to hold the penis upright to straighten the penile urethra. Some resistance may be encountered as the catheter reaches the level of the external sphincter. Instruct the patient to breathe deeply to relax the sphincter. Apply slow continuous pressure to the catheter and advance the catheter to the level of the side channel. Before inflating the balloon, confirm proper placement by observing the flow of urine into the collecting tube. If no urine is returned, the catheter is probably obstructed by lubricating jelly and should be flushed with normal saline. Gentle palpation of the bladder may also promote urinary flow into the collecting system. Once proper placement is confirmed, inflate the retention balloon with 10 milliliters of water. Air or normal saline should not be used. It is important to inflate the balloon while the catheter is fully inserted to avoid inflation while the balloon is still in the urethra. Next, gently pull the catheter back to seat the retention balloon against the bladder wall. If the patient is uncircumcised, pull the foreskin back over the glands to prevent the development of a paraphimosis. Finally, secure the collection tubing to either the thigh or the anterior abdominal wall and hang the collection bag in a dependent position to prevent the reflux of drained urine back into the bladder. Catheterization may be difficult to perform in patients with prostatic enlargement. This is usually sensed as resistance to the advancement of the catheter at approximately 16 to 20 centimeters. Use of the Coudet catheter may alleviate this problem, since its firm, curved tip may traverse the exaggerated curve of the prostatic urethra. If a Coudet catheter is not available, a larger Foley catheter, size 20 to 24 French, may be used. Although counterintuitive, the use of the smaller catheter does not facilitate catheterization, since it is less firm than a larger catheter and is likely to kink at the neck of the bladder. Urology consultation should be obtained if you are unable to enter or advance through the urethra due to phimosis, meatal stenosis, or urethral stricture. The catheter should never be forcefully advanced, as this is unlikely to be successful and may result in urethral trauma. Urinary tract infections are common after urethral catheterization. Although many cases are limited to asymptomatic bacteriuria, significant illness or death may result. The single best way to avoid catheter-related infections is to avoid catheterization whenever possible. Additional complications of urethral catheterization include paraphimosis, trauma to the urethra and bladder, and non-deflation of the retention balloon.
This is a video in clinical medicine from the New England Journal of Medicine.
This video will demonstrate how to perform a comprehensive pelvic examination, which includes an examination of the external genitalia, a Papa-Nicolau test, a bimanual examination, as well as a rectovaginal examination. Women should undergo a pelvic examination when they have vulvar and/or vaginal complaints such as pain, discharge, abnormal bleeding, itching, and/or a mass. A pelvic examination is also indicated when pregnancy is suspected or proven and in women who have been exposed to sexually transmitted infections. Pap testing is the main screening tool for detecting precancerous lesions of the cervix. We will now highlight the American Cancer Society recommendations. Cervical cancer screening should begin approximately 3 years after the onset of vaginal intercourse, or no later than 21 years of age, and should be performed annually until age 30. Women aged 30 years or older who have had 3 consecutive normal Pap results can be screened every 3 years, unless they have risk factors such as infection with the human immunodeficiency virus, immunosuppression, or a new sexual partner. Pap testing can be discontinued in women who have had a total hysterectomy for benign lesions, or in low-risk women once they have reached 65 to 70 years of age. Before you perform this procedure, elicit the patient's recent history. Ask about the date of her last menstrual period and review her gynecological and obstetrical history, including any history of abnormal Pap smears and the type of birth control she is using or has used. For women undergoing routine screening, inquire about issues relevant to the vulva and vagina, such as whether she has itching, abnormal discharge, or dyspareunia. Also, ask about total number of sexual partners, patient's sexual orientation, if there is concern about the possibility of a sexually transmitted infection, or has experienced prior discomfort during a pelvic exam. Before examining the patient, wash your hands and put on gloves. Before starting the procedure, you will need to gather the following materials: speculum, gloves, water-soluble lubricant, and materials for the Pap test: brush and liquid-based fixative or wooden spatula, cervical brush, and glass slide with fixative. You may also need wet mount materials: pH paper, glass slides, cotton swabs, potassium hydroxide, and saline, as well as materials for testing for sexually transmitted infections. Depending on your clinic setting, testing for gonorrhea and chlamydia may include DNA probes, culture media, and/or PCR. Ensure that the examination light is working, that the speculum blades approximate where the speculum is closed, and that the screw on the speculum thumb piece is functional. Make sure the patient has emptied her bladder before the exam, as a full bladder may compress the vaginal canal and obstruct the view of the cervix. Provide some privacy as the patient changes into a gown. Ask her to sit on the examination table with a drape covering her legs. Make sure she has been offered the opportunity to have a chaperone in the room during the examination. Help guide the patient into the lithotomy position by placing her feet in the stirrups, having her slide her buttocks to the edge of the examining table, and having her relax her legs into abduction. She should be draped in a way that allows minimal exposure, and you should be able to easily visualize her vulva, but still keep her knees covered. Examine the entire vulva, perianal area, vaginal canal, and Bartholin glands. Observe for erythema, swelling, excoriation, rashes, lesions, masses, trauma, and palpate for tenderness. To examine the Bartholin glands, separate the labia with your non-dominant hand and then place the index finger of your dominant hand into the introitus. Gently compress the anterolateral tissue bilaterally. This is the area of the Bartholin gland. Examine the patient for areas of discomfort, irritation, or pain. Some of the more common findings include lichen sclerosis, a chronic inflammatory dermatosis that results in white plaques with epidermal atrophy. Vulvar dermatitis results in redness and excoriation. Vulvar ulceration. Condyloma is seen here as multiple cauliflower-like eruptions, and vaginal varicosities, often associated with pregnancy. Put on a clean pair of gloves and warm the speculum with warm water. Ensure the temperature is comfortable for her by touching it to her thigh. Apply a water-based lubricant to the speculum. Insert the speculum gently and slowly at a slight downward angle through the introitus. Once past the introitus, insert the speculum further into the vagina using a downward pressure to a depth of 4 to 5 centimeters. The speculum handle should be approximately 2 centimeters away from the introitus before opening the speculum blades. After inserting the speculum, if the cervix is not visualized, identify the folds of the vagina in front of the speculum opening. These vaginal folds aid in identifying the cervix. Close the speculum, back up 1 to 2 centimeters, and then gently insert the speculum further into the vagina using downward pressure in the direction of the vaginal folds. Reopen the speculum slightly and search again for the cervix. This maneuver may need to be repeated several times. After inserting the speculum, open the speculum slightly and look for the cervix. The cervix has a smooth, firm appearance, no vaginal rugae. You may only see the anterior or posterior portion of the cervix. If the cervix is visualized immediately, open the speculum further to encircle the cervix, and then lock the speculum in place by turning down the screw on the speculum thumb piece. There are several methods used to obtain cervical cells for examination: the liquid-based cytologic screening technique and the traditional glass slide sampling technique will be reviewed here. In both techniques, it is important to obtain samples of both the endocervix and the exocervix. With liquid-based cytologic screening, use a broom-shaped brush to obtain the samples. Once you see the cervix, place the brush against the cervix and gently rotate the brush several times. Remove the brush from the vagina, disconnect the brush tip, and place it in the liquid-based pap container. To keep the outside of the pap container from contamination, make sure the gloved hand holding the container is clean, or ask an assistant to hold the container. The traditional glass slide sample technique is shown here on the same patient. It is unnecessary to perform both techniques. To obtain a traditional glass slide sample of cervical cells, place the wooden spatula on the face of the cervix and rotate 360 degrees. Then place the endobrush in the cervical os and turn 360 degrees. Transfer specimen to the slide by rolling or twisting the spatula and brush on the slide. Apply fixative. Before or after obtaining the pap smear, you can obtain a specimen for wet mount and cervical cultures. Using a cotton-tipped swab, obtain a sample of the vaginal discharge in the posterior or anterior fornix or along the vaginal walls. Swab this sample onto a piece of pH paper to determine the vaginal pH. A healthy adult female vaginal pH is 4. This will appear yellow on the pH paper. If the vaginal pH is more alkalotic, blue, you should be concerned about possible infection, for example, bacterial vaginosis. Then swab the sample onto a glass slide, apply potassium hydroxide and saline to opposite sides of the slide, and then cover the slide with cover slips. Using the microscope, examine the saline prep sample for clue cells and trichomonads. Trichomonads will appear to vibrate on the slide. Examine the potassium hydroxide prep sample for budding hyphae. To perform DNA, gonococcal, or chlamydia probes, position a cotton-tipped swab in the cervical os for 30 seconds. Place this end in the medium provided, and then secure the top. Make sure the patient's name and other necessary information are on the container. In addition, the pathologist will require information such as the date of the last menstrual period and a history of prior abnormal Pap smears. Note whether the patient is postmenopausal, pregnant, on hormonal contraception, and/or using an IUD, or on hormone replacement therapy. Warn the patient before unlocking and removing the speculum. Unscrew the lock in the speculum handle and gently detach the blades from the cervix. As you are removing the speculum, slowly close the blades. The blades should be completely closed when exiting the introitus. Make sure you examine the walls of the vagina as you are retracting the speculum. Let the patient know she may have a small amount of bleeding after Pap smear sampling. At this time, a bimanual examination can be performed if indicated. To avoid contamination of the patient's abdomen when switching from the speculum exam to the bimanual exam, remove or replace the glove on your non-dominant hand. Place the index finger and middle finger of your dominant hand into the vagina to examine the vagina, cervix, uterus, and adnexae. The abdominal hand should be used to sweep the pelvic organs downward, while the vaginal hand is simultaneously elevating them. It should only take a moment to determine the size, shape, symmetry, mobility, position, and consistency of the uterus. Check the adnexal regions for the presence of appropriately sized.
This is a video in clinical medicine from the New England Journal of Medicine.
Female urethral catheterization, the insertion of a catheter through the urethra into the urinary bladder to permit drainage of urine, is a fundamental skill for the practicing healthcare professional. This video discusses the indications for catheterization, the equipment available, the current methods of catheter insertion and maintenance, potential complications, and how to troubleshoot common problems. Female urethral catheterization is indicated for both therapeutic and diagnostic purposes. Urinary catheterization is therapeutic in several circumstances. It permits effective bladder drainage in patients with acute or chronic urinary retention. A urinary catheter may be used to instill medication for local intravesical therapy. Urethral catheterization and irrigation may be used to remove blood and clots from the urinary bladder in patients with gross hematuria. Urethral catheterization facilitates diagnosis in several circumstances, such as obtaining sterile urine specimens for urinalysis or culture, measuring post-void residual volumes, and monitoring urinary output during surgery or in critically ill patients. Catheterization also allows installation of contrast media during various imaging procedures, such as voiding cystourethography and retrograde urethography. Suspected or confirmed urethral injury can be a contraindication to catheterization. Urethral injuries are rare and are most commonly a result of pelvic fractures or multisystem injuries. If blood is found at the urethral meatus, or if there is evidence of gross hematuria or a perineal hematoma, then urethral or bladder neck injury should be considered. If there is any question of injury, both genital and rectal exams should be performed, and retrograde urethography considered before catheterization is attempted. In this setting, consultation with a specialist prior to catheterization, if feasible and if time permits, is prudent. Patients who are unable to cooperate may require extra time for calming or may even need sedation for the procedure. Consultation with a urologist should be considered in patients with a recent history of urethral or bladder surgery. Since urinary catheterization can cause infection or trauma, this technique should not be used for routine management of urinary incontinence, but should be reserved for circumstances in which non-invasive methods fail. A variety of pre-packaged urethral catheterization kits are commercially available. A typical kit includes a water-absorbent underpad, a sterile fenestrated drape, sterile gloves, 4 or 5 swabs, forceps, an antiseptic solution, a 10 cc syringe pre-filled with lubricating jelly, a 10 cc syringe pre-filled with sterile water for balloon inflation, a pre-connected closed Foley system, and a specimen container with cap and label. Other items, such as those for securing the system to the patient or the bed, may need to be gathered separately. There are many types of catheters varying in construction material, design, and size. Catheters are most often made from latex. However, the use of silicone catheters is becoming more widespread, as latex hypersensitivity and even anaphylaxis related to latex are increasingly recognized. Silver alloy hydrogel-coated latex catheters may decrease bacterial colonization and growth and should be considered for patients with recurrent infections. The Foley catheter is most frequently used in female patients requiring an indwelling catheter. It is a double-lumen, straight-tip catheter with a balloon at its end that is inflated after insertion into the bladder to help retain the position of the catheter. Other types of catheters include the triple-lumen catheter, which can be used for continuous bladder irrigation after bladder surgery or for patients requiring irrigation to prevent retention of clots within the bladder, and the straight catheter, which may be used for intermittent catheterization or on a one-time basis to obtain a urine sample. The size of the catheter is categorized most frequently in French units, circumference in millimeters. The narrowest and softest tube that can effectively be used is recommended, thereby limiting discomfort and decreasing the risk of infection. Smaller catheters are used for narrow urethras or in patients with a history of strictures or scarring. 14 French to 16 French catheters are appropriate for most adult women. Larger catheters, 18 to 24 French, may be used in patients who are at risk for obstruction of the lumen, for example, patients with gross hematuria with clots. Explain the procedure to the patient, addressing any specific questions or concerns. Possible complications such as urethral and bladder trauma, bleeding, and infection should be discussed. With the bed flat, the patient should lie supine in a lithotomy position or a frog-legged position with legs apart and feet together. If available, a table with stirrups may be used to facilitate visualization. Begin by inspecting the genital area to identify the urethral meatus. The adult female urethral meatus, typically 5 to 6 millimeters in diameter, is an ovoid opening with the long axis on the vertical. The female urethra is a fibromuscular tube that is approximately 3.5 to 4 centimeters long. It is located below the clitoris and above the vaginal orifice in the superior fornix of the vulva. Inspect the sterile catheterization kit. Remove it from its outer packaging and place it within reach. Open the inner paper wrapping to form a sterile field. To reduce the risk of infection, urethral catheterization should be performed under sterile conditions, which include wearing sterile gloves when handling the equipment and throughout the procedure. To avoid contaminating the sterile gloves, once you have washed your hands carefully, retrieve the absorbent pad from the top of the kit and place it with the plastic side down beneath the patient's buttocks before putting on the sterile gloves. If pad placement is difficult, re-wash your hands before putting on sterile gloves and proceeding. Then, cover the patient's abdomen and superior pubic region with the fenestrated drape. Now, with the patient draped, organize the contents of the tray on the sterile field. Pour the antiseptic solution over the preparation swabs in the tray compartment. Set aside 1 or 2 of the swabs, in case excess antiseptic solution needs to be blotted. Squeeze some sterile catheter lubricant onto the tray or into the sterile field to lubricate the catheter tip before inserting it into the urethra. After preparing the tray, using your non-dominant hand, identify the urethra by spreading the labia majora and minora, by placing the thumb and index finger medial to the inner labia, spreading the finger slightly, and with gentle traction, pulling upward toward the head of the patient. This hand is no longer sterile. Do not release this non-sterile hand from this position. After you identify the urethral meatus, use an expanding circular motion to clean the opening with the remaining prep swabs. Lubricate the distal end of the catheter with the sterile jelly. Though lubrication is necessary, too much lubricant may delay the flow of urine. Holding the catheter in the dominant hand, gently introduce the catheter tip into the meatus and slowly advance it through the urethra into the bladder. If the catheter is accidentally inserted into the vagina, or if the tip is contaminated, discard it and obtain a new sterile catheter before proceeding. Because the female urethra is short, urine may begin to flow before the balloon has completely entered the bladder. Once you can see urine flowing through the catheter, continue to advance the catheter for another 3 to 5 centimeters to ensure the complete insertion of the balloon in the bladder. You may feel resistance before the catheter is fully inserted in the bladder at the external sphincter. Instruct the patient to breathe deeply and to relax, which should facilitate passage of the catheter into the bladder. Never force the catheter through the urethra, as this may cause urethral trauma or perforation. Insert the catheter completely into the urethra, and do not inflate the balloon until there is return of urine in order to avoid trauma due to intraurethral inflation. Inject the entire 10 cc syringe of sterile water to inflate the 5 cc balloon completely. Note that the labeled volume of the balloon does not indicate the higher volume required to fill it properly. Partially filled balloons may lead to catheter displacement and urethral or bladder trauma. Saline should not be used because it may cause crystallization and valve malfunction. Air also should not be used because it allows the balloon to float in the bladder, possibly kinking the catheter. With the balloon completely inflated, pull gently on the catheter to fix the balloon against the bladder wall. Secure the catheter to the medial thigh of the patient with tape or a catheter securing device. Finally, place the drainage bag in a convenient location below the level of the bladder. To remove an indwelling catheter equipped with a balloon, first deflate the balloon completely, ensuring that all of the previously injected water is retrieved. After that, gently pull out the catheter. If there is difficulty in removing the catheter, consultation with a specialist is advised. The most common complications of urethral catheterization are trauma and infection. Trauma may result from incorrect insertion of the catheter into the urethra or removal of the catheter with the balloon inflated. Strictures, narrowing, and scarring of the urethra may result from such traumatic injury and can make catheterization difficult. Infection is common in patients with indwelling catheters. Within 48 hours, up to 85% of catheters may be colonized with bacteria, which may lead to bacteriuria. The best way to prevent complications is to avoid catheterization whenever possible. Continue to review the patient's need for an indwelling catheter and remove it as soon as possible. The urethra of some female patients may be difficult to catheterize for various reasons that include previous operative procedures, obesity, previous childbirth, and anatomical variants of pelvic organs. Catheterization may also be difficult in patients for whom positioning may be limited, such as those with chronic arthritis. If you are unable to pass the catheter through the urethra, or if you encounter resistance, the urethra may be kinked because of pelvic organ prolapse. If the prolapse is large and protrudes from the vaginal opening, it may be necessary to reduce it by gently applying pressure to the prolapse and guiding it back into the vagina. If the urethra is not easily visualized, place the index finger of your non-sterile hand inside the vaginal orifice and gently apply pressure superiorly, both to straighten the urethra and to allow the finger to serve as a guide into the superior urethral opening. If you feel the catheter beside the finger, it is incorrectly placed inside the vagina. In this case, the catheter should be removed and properly discarded. Use a new sterile catheter and attempt catheterization again. In morbidly obese patients, an assistant is often necessary to aid in retraction and to maintain sterility. If the flow of urine is slow or non-existent, the catheter may be obstructed or in the wrong site, or the bladder may be empty. Flush the catheter with saline. If saline or urine freely returns, the catheter is properly inserted. Massaging the bladder by gently pressing on the patient's abdomen may also facilitate the free flow of urine. Female urethral catheterization performed with proper sterile technique is an invaluable, reliable method for both therapeutic and diagnostic purposes. It is important for all practicing health professionals to master the proper insertion technique and understand the risks and benefits of the procedure.
This is a video in clinical medicine from the New England Journal of Medicine.
Patients frequently present to primary care offices, urgent care, and emergency departments with musculoskeletal injuries such as fractures, sprains, and dislocations. Many distal extremity injuries can be initially managed in an outpatient setting using basic splinting techniques. Splinting immobilizes injured extremities and prevents further injury, decreases pain and bleeding, and allows healing to begin. While there are many indications for splinting an extremity, three main types of injuries are commonly treated in outpatient settings. Fractures. Splinting is used to stabilize fractures of the upper and lower extremity, providing patient comfort and maintaining proper bone alignment. Dislocations. After reduction of a dislocated joint, splinting is used to maintain anatomic reduction during healing. Sprains. Splinting may be used to maintain the position of function and to alleviate pain for patients with ligamentous sprains. While there are no absolute contraindications to applying a temporary splint to an injured extremity, there are some unique circumstances that must be considered. The natural swelling of an extremity that occurs in the initial phase of healing can lead to challenges in determining the safest method of immobilization. Circumferential casting of an extremity fracture is often avoided in the acute setting, as continued swelling can lead to neurovascular compromise inside a rigid cast. Splints are an excellent alternative because they provide the necessary immobilization while allowing for the natural swelling process to occur without marked neurovascular compression. For injuries that are prone to severe swelling, even a splint can become restrictive as the swelling increases. Additional padding may allow room for expansion in these circumstances. The presence of neurovascular compromise at presentation mandates reduction of the injury to establish vascular perfusion of the extremity prior to splinting and definitive care. An orthopedic specialist should be consulted for fractures requiring urgent surgical evaluation, such as open fractures, which may require operative management. Temporary splints can be placed to alleviate pain and to prevent additional injury while awaiting evaluation by a specialist. Use appropriate universal precautions for potential exposure to bodily fluids when open wounds are present. The materials needed for basic extremity splint placement include a stockinette, cotton padding, plaster or fiberglass rolls or sheets, elastic bandages with clips or adhesive tape, heavy-duty scissors, and a bucket of water. Use sheets or pads to protect the patient's clothing during splint application whenever possible. As an alternative to plaster rolls or sheets, you may also use prefabricated splint materials. Before placing a splint, carefully examine the injured extremity. Failure to expose the injury site fully may result in unidentified injuries and subsequent poor outcomes. Evaluate pulses, motor function, and sensory function to determine whether emergency intervention or evaluation by a specialist is necessary. Treat skin or soft tissue injuries appropriately before placing a splint. Analgesics or anesthetics may be necessary to control pain during the splinting procedure. Place the patient in a comfortable position that allows you to have adequate access to all sides of the injured extremity. Remove all jewelry from the involved extremity before beginning splint placement. This section demonstrates the application of a volar splint to an upper extremity. Apply the stockinette to the extremity, avoiding wrinkles and using sufficient length to extend 10 centimeters beyond each end of the splint. Use scissors to cut an opening for the thumb. Cut a small hole in the stockinette where it lies across the base of the thumb and then pull over the digit to prevent wrinkles. Use cotton padding material to pad the injured extremity for comfort and to allow for anticipated swelling. Wrap the padding around the extremity, overlapping the previous layer by 25 to 50% to place 2 layers of padding over the entire area. In areas of bony prominence or expected irritation, apply extra layers of padding. If substantial swelling is expected, continue wrapping for 3 to 4 layers of protection. The cotton material can easily be stretched or torn as needed for uniform application. Take care to avoid too much circumferential pressure caused by excessive stretching of the padding during the application. Select a piece of dry plaster that is slightly wider than the limb to be immobilized. Measure the length of the splint material required, and then cut or tear the dry plaster material to the appropriate length. Use at least 8 layers of plaster material for upper extremity splints and 12 layers for lower extremity splints to provide adequate strength to the completed splint. Consider using the unaffected extremity to measure the length of plaster that will be needed to limit the discomfort caused by moving the injured limb. Use additional layers of plaster if extra strength is required, keeping the total splint thickness less than 24 layers to minimize the risk of thermal injury from the plaster as it dries. Fill a bucket with lukewarm water less than 50 degrees Celsius and immerse the plaster material until it is saturated. Hold the wet plaster sheets vertically over the bucket and use 2 fingers to manually compress the layers in a downward motion. This removes wrinkles and excess water and will laminate the layers together. Place the plaster material over the cotton padding. Smooth the plaster to mold to the contours of the extremity in the appropriate anatomical position. Apply an additional layer of cotton padding to hold the splint in place and fold the ends of the stockinette back over the splint. Use an elastic bandage to secure the splint in place by wrapping it in a distal to proximal direction. Avoid excessive compression of the extremity when applying this elastic bandage. Before the plaster dries, place the extremity in the desired anatomic position. Use the palms of your hands to mold the splint gently to the extremity, taking care to avoid creating indentations that might lead to pressure points. Allow the splint to dry without further manipulation or patient movement. Avoid resting the splint on a pillow during this time, as heat buildup can cause thermal injuries as the plaster dries. Once the splint has dried completely, check for adequate immobilization, strength of splint, and patient comfort. A volar splint can be used to immobilize a sprained wrist, a triquetral fracture or lunate dislocation, or a 2nd through 5th metacarpal head fracture. This splint should extend along the volar aspect of the forearm from the metacarpal heads to just proximal to the radial head, allowing unencumbered flexion of the elbow. Place the forearm in a neutral position with the thumb upward and the wrist in 20 degrees of extension. Ulnar gutter splints are designed to immobilize fractures along the ulnar aspect of the hand, including injuries to the 4th and 5th phalanges and metacarpals. This splint extends from the distal interphalangeal joint of the little finger to the proximal forearm. Place the forearm in a neutral position with the wrist in 20 degrees of extension. The metacarpal phalangeal joints should be flexed at 50 degrees, with the proximal and distal interphalangeal joints in slight flexion. Thumb spica splints are applied to the radial aspect of the forearm to immobilize the thumb and prevent flexion and extension of the wrist. This splint is useful for fractures of the scaphoid and lunate, first metacarpal, and thumb. This splint extends from the tip of the thumb to the proximal forearm. Place the forearm in a neutral position with the wrist in 20 degrees of extension and the thumb slightly flexed. A long arm splint will immobilize proximal forearm and elbow fractures. It can also provide temporary stabilization of intra-articular fractures of the distal humerus and olecranon while awaiting surgical care. When splinting a joint at an angle, be sure to wrap the extremity in the expected final position. Avoid excessive padding around the anterior aspect of the elbow joint in long-arm splints, as this can result in skin pressure points and swelling under the splint. This splint prevents flexion and extension of the elbow and limits supination and pronation of the forearm. It extends along the posterior arm from the wrist to the proximal humerus. Place the elbow in 90 degrees of flexion while maintaining a neutral position for the forearm and wrist. A forearm sugar tong splint is used for wrist and distal forearm fractures. It immobilizes the wrist and forearm and prevents supination and pronation of the forearm. The splint extends from the metacarpal phalangio joints on the dorsum of the hand, along the forearm, around the elbow, and back to the volar aspect of the mid-palmar crease. Place the elbow in 90 degrees of flexion while maintaining a neutral position for the forearm and wrist. A posterior leg splint is used to stabilize severe sprains, reduced ankle dislocations, and fractures of the distal leg, ankle, and foot. The splint extends from the metatarsal heads to just below the fibular head while maintaining a 90-degree angle at the ankle. Be sure to keep the fibular head free to avoid compression of the adjacent perineal nerve. Lower extremity splints are not designed for weight bearing, and the patient should use crutches to walk safely. Adding a lateral stirrup component to a posterior leg splint increases splint stability and prevents inversion or eversion of the ankle. This splint provides greater mobilization and stability for fractures near the ankle. The stirrup splint is similar to the sugar tong splint for the upper extremity. Apply the splint to the medial and lateral leg extending from the tibial tuberosity to wrap around the foot and end just below the fibular head. Mold the splint with the ankle at a 90-degree angle. Commercially available ankle splints may be used to enhance comfort after a sprain, but typically do not provide the necessary stability for fractures. Similar products are available for upper extremity sprains, such as a soft wrist splint. Prefabricated splinting materials are available and can be used to create a wide variety of splints for injured extremities using modifications of the techniques demonstrated in this video. Re-evaluate the extremity immediately after completing the splint placement. Evaluate distal motor and sensory function. Palpate for pulses, evaluate the color of the extremity, and assess for appropriate capillary refill. Be sure that the completed splint is comfortable and not overly restrictive, and that the patient's pain is controlled. Address any discomfort by applying additional cotton padding or loosening the elastic bandage. Typical care after the application of a splint should include extremity elevation, application of ice packs, administration of analgesics, and appropriate communication of instructions for medical follow-up. Instruct the patient to keep the splint clean and dry and not to remove it until instructed. Give the patient verbal instructions and an easily understood written list of signs and symptoms that would necessitate urgent return for further evaluation. These include development of any signs of neurovascular compromise or compartment syndrome, such as increased swelling, worsening of pain, discoloration of the distal extremity, difficulty moving the fingers or toes, or change in sensory function. Splinting plays a major role in the initial management of musculoskeletal injuries, particularly those involving extremity fractures, joint dislocations, and severe sprains. A properly applied splint will stabilize the injured extremity, increase patient comfort, and allow the healing process to begin. Depending on the type of injury, a splint may be the only treatment required, or it may be an important temporizing measure until further evaluation or surgical intervention is completed.
This is a video in clinical medicine from the New England Journal of Medicine.
The purpose of this video is to demonstrate the equipment and techniques used to provide intravenous conscious sedation for minor procedures in adults. Practice guidelines may vary in different regions of the world. The American Society of Anesthesiologists has developed practice guidelines for sedation and analgesia by non-anesthesiologists and defines sedation as a continuum, but considers 3 different levels of sedation. Minimal sedation provides a drug-induced state of anxiolysis during which patients respond normally to verbal commands. Moderate sedation, analgesia, or conscious sedation creates a drug-induced depression of consciousness during which patients respond purposefully to verbal commands, either alone or accompanied by light tactile stimulation. No interventions should be required to maintain a patent airway during conscious sedation, and spontaneous ventilation should be adequate. Deep sedation, analgesia, is a drug-induced depression of consciousness during which patients cannot be easily aroused but respond purposefully following repeated or painful stimulation. The ability to maintain ventilatory function may be impaired. Procedures that are particularly invasive or painful may require deep sedation analgesia rather than conscious sedation. Conscious sedation may be considered for any procedure that causes patient discomfort or pain. Contraindications for conscious sedation include a patient with a past history of allergic reaction to analgesic or sedative medications, unstable cardiorespiratory function, and a non-fasting state. Patients undergoing conscious sedation should have had no clear liquids by mouth for 2 hours before the procedure and no food for 6 to 8 hours before the procedure. As sedation is a continuum, a patient undergoing conscious sedation may become deeply sedated and develop impaired airway reflexes and hypotension. Thus, the clinician providing sedation must be capable of providing cardiorespiratory support to one level beyond the anticipated level of sedation. This means, if you intend to induce conscious sedation in a patient, you must be capable of supporting your patient's ventilation, oxygenation, and hemodynamics in the event that he or she becomes deeply sedated. Ultimately, it is your responsibility to ensure that conscious sedation is performed by qualified personnel. Many hospitals and institutions have developed their own guidelines and credentialing systems for sedation providers. It is your responsibility to know these guidelines and to be appropriately credentialed. A thorough history and physical exam is required immediately before a patient is given conscious sedation. Informed patient consent is required. The physical exam should include vital signs and should focus on evaluation of the patient's airway, neurologic, and cardiorespiratory systems. Physical signs that a patient has a potentially difficult airway include obesity, a limited range of motion in the neck, a small mandible, and a limited ability to open his or her mouth. If there are concerns that the patient may have a difficult airway, such as a history of severe sleep apnea or marked obesity, an anesthesiology consult should be considered. Appropriate laboratory tests should be obtained and reviewed, particularly in patients who have potential risks for altered drug metabolism, such as those with liver or kidney disease. Since sedation is a continuum, and a patient's level of sedation can change rapidly, you should have the ability to monitor the patient's level of consciousness, hemodynamics, ventilation, and oxygenation. The patient must have a working intravenous line prior to initiating conscious sedation. Emergency equipment for intubation and resuscitation must be immediately available. You must know how to use this equipment and how to administer appropriate medications in case cardiopulmonary resuscitation is required. Monitors include hemodynamic variables of heart rate and blood pressure. End-tidal carbon dioxide monitoring may improve detection of airway obstruction. Oxygenation is monitored with a continuous pulse oximeter. Vital signs should be recorded at least every 5 minutes while the patient is being sedated. In order to provide conscious sedation, you must know the pharmacology and contraindications for every medication that you use or may use. This brief set of descriptions constitutes an overview. You should review each medication in detail before proceeding with conscious sedation. The benzodiazepine, midazolam, is a commonly used sedative. The opioid agonist, fentanyl, is a commonly used analgesic. Both are available in intravenous formulations. These drugs have a rapid onset and offset. They are titratable, and pharmacologic antagonists are available to reverse their effects in the event of an overdose. Midazolam is a potent benzodiazepine that may be administered intravenously. Its action on gamma-aminobutyric acid, or GABA receptors in the brain, causes anxiolysis and amnesia. Clinically effective doses for sedation vary widely. It is important to titrate the drug to the desired effect. For adults, a dose of 0.5 milligrams can be administered intravenously and repeated as needed every 5 minutes. Flumazenil is a benzodiazepine antagonist used to treat benzodiazepine overdose. To reverse the sedative effects of midazolam administered for conscious sedation, an initial dose of 0.2 milligrams of flumazenil is administered intravenously over 15 seconds. If the desired level of consciousness is not obtained after 1 minute, a second dose of 0.2 milligrams can be injected, and that dose repeated at 1-minute intervals to a maximum total dose of 1 milligram. You should avoid giving flumazenil to patients with severe liver disease or to patients who require long-term benzodiazepine use, since the drug is associated with seizures. Patients given flumazenil need to be monitored closely, because they may become sedated again when the flumazenil effect abates. Fentanyl is a potent opioid that may be delivered by multiple routes. Intravenous fentanyl acts on mu-opioid receptors in the brain and causes rapid onset analgesia and sedation. Clinically effective doses for sedation vary widely. It is important to titrate to the desired effect. For adults, an intravenous dose of 25 micrograms can be administered, and that dose repeated as needed every 5 minutes. Naloxone is an opioid antagonist used to reverse the respiratory depression of opioids. The dose of naloxone should be titrated to patient response. To reverse respiratory depression, naloxone may be administered in increments of 0.1 to 0.2 milligrams intravenously at 2 to 3 minute intervals. Larger than necessary doses of naloxone may cause pain and hypertension. Rapid reversal may cause nausea, vomiting, and diaphoresis. Naloxone administration should be avoided in patients physically dependent on opioids. If you give naloxone to reverse the action of opioids, you must monitor the patient, since the duration of action of some opioids may outlast the duration of action of naloxone. One clinician should be responsible for providing conscious sedation, while another clinician performs the intended procedure. Adequate equipment for monitoring and patient support must be prepared. Before starting conscious sedation, make sure you have the following equipment: an ambu bag and a source of oxygen in the event you need to support your patient's oxygenation and ventilation. Both rigid and flexible suction catheter tips and active suction devices should be at hand. You should continuously monitor your patient's level of consciousness. Other monitors include a blood pressure measurement device, a pulse oximeter, and devices to monitor heart rate and respiratory rate. Although current American Society of Anesthesiologists guidelines do not absolutely require them for conscious sedation, we also recommend an electrocardiogram and an end-tidal carbon dioxide detector. Airway equipment, such as a face mask or oral and nasal airways, should be present. You will need equipment for obtaining intravenous access, such as fluids, catheters, needles, and syringes. You should have the drugs that you will or might need to use, including sedatives, analgesics, reversal medications, and emergency medications. Finally, an emergency or crash cart with advanced airway devices and medications must be immediately available. There are many different ways to induce conscious sedation. As a general rule, start with small incremental doses and titrate to effect. When combining sedatives and analgesics, reduce the dose of each. You may start with midazolam boluses every 5 minutes, with constant re-evaluation of the patient's status. Start with a small intravenous dose, such as 0.5 milligrams, and evaluate the patient's response. At this point, if necessary, you may inject an intravenous bolus of a small amount of fentanyl, initially 25 micrograms, paying particular attention to ensure that the patient's respiratory function is preserved. Depending on the length of the procedure and the patient's response, you may repeat the dose of the medications as required to maintain conscious sedation. Each patient responds differently to sedatives and analgesics, and you must remain vigilant in monitoring your patient's status throughout the procedure. The most serious complications of conscious sedation are when a patient becomes deeply sedated and develops respiratory and cardiovascular depression. Respiratory depression, or apnea, can lead to death, and thus conscious sedation requires appropriate consent, adequate preparation, monitoring, and qualified personnel. Cardiovascular depression, such as hypotension, can be associated with respiratory depression or can occur in isolation. If hypotension develops, sedative medication should be held, and intravenous fluids and medications such as phenylephrine or ephedrine should be used to increase the blood pressure to baseline. After conscious sedation is complete, the patient should be monitored until he or she returns to a baseline level of consciousness. Conscious sedation can provide benefits to both the patient who is undergoing and the clinician who is performing an invasive procedure. Sedation is a continuum, and clinicians performing conscious sedation must be able to provide cardiorespiratory support to one level beyond the intended level of sedation. A thorough patient evaluation is required to identify any contraindications. When performing conscious sedation, appropriate monitoring and equipment for resuscitation must be available. The clinician must be knowledgeable in the pharmacology of the chosen sedatives and analgesics. The most serious complication of conscious sedation in a patient is respiratory and cardiovascular depression. At the completion of the procedure, the patient should be monitored until he or she returns to a baseline level of consciousness.
Primary percutaneous coronary intervention for acute myocardial infarction with ST segment elevation. Under normal circumstances, the flow of oxygenated blood to the myocardium in the coronary arteries is unimpeded. As a result, the oxygen demands of the heart muscle perfused by the artery are met by an appropriate oxygen supply. In this drawing, the myocardium on the anterior wall of the left ventricle is perfused normally by the left coronary artery. The electrocardiogram reflecting that area of myocardium is normal. Over time, an atherosclerotic plaque develops in the coronary artery. For reasons that are not well understood, the layer of endothelial cells covering the plaque, the so-called fibrous cap, may rupture, thereby becoming a nidus for thrombus formation. Within minutes, an occlusive thrombus forms. Blood flow in the coronary artery ceases, and all the myocardium supplied by the artery becomes ischemic. This is reflected on the electrocardiogram as ST segment elevation. If the ischemia is unrelieved, all the ischemic myocardium will die within a few hours. The objective of balloon angioplasty and stent placement is to restore blood flow in the occluded coronary artery as quickly as possible, thereby preventing ischemic myocardium from dying. During balloon angioplasty, a thin metal guide wire is advanced into the occluded coronary artery and past the occlusive thrombus, after which a deflated balloon catheter is advanced over the wire, positioned at the site of the occlusion, and inflated for 1 to 3 minutes. Then the balloon is deflated and retracted. Coronary arterial blood flow is restored. thereby relieving the ischemia. As a result, the ST segment elevation begins to resolve. Alternatively, blood flow in the occluded coronary artery may be restored by the placement of a metal stent. A thin metal guide wire is advanced into the occluded coronary artery and past the occlusive thrombus, after which a deflated balloon catheter with a metal stent affixed to it is advanced over the wire, positioned at the site of occlusion, and inflated for 1 to 3 minutes. Inflation of the balloon expands the stent. The balloon is then deflated and retracted. The now expanded metal stent remains in place. Coronary arterial blood flow is restored, thereby relieving the ischemia. The ST segment elevation begins to resolve. This is a video in clinical medicine from the New England Journal of Medicine.
Incision and drainage is the primary therapy for cutaneous abscess management, as antibiotic treatment alone is inadequate for treating many of these loculated collections of infectious material. Most localized skin abscesses without associated cellulitis can be managed with simple incision and drainage and do not require antibiotic treatment. Cutaneous abscesses have been described in all areas of the body, but are most commonly found in the axilla, buttocks, and extremities. This outpatient procedure is appropriate for many office settings, as well as for urgent care and emergency department practice environments. Diagnosis of a skin abscess is the first step in a successful procedure. This can be accomplished in 3 ways. Physical examination of the affected area will often allow diagnosis of an underlying abscess based on swelling, pain, redness, and fluctuance. Spontaneously draining skin abscesses are also amenable to diagnosis by physical examination alone. Needle aspiration of a suspected skin abscess can assist the clinician in making the diagnosis of a localized abscess when results of physical examination are equivocal. Bedside ultrasound is a valuable adjunctive tool for identification of localized areas of fluid under the skin that may represent isolated areas of infection. An abscess that is diagnosed in one of these 3 ways may be appropriate for incision and drainage if it is larger than approximately 5 millimeters and found in an accessible location. Extremely large or deep abscesses in areas difficult to anesthetize may be more appropriate to treat in a formal operating room setting. Abscesses of the palms, soles, or nasolabial folds can be associated with complications and may require consultation with an appropriate specialist. Incision and drainage is not indicated for cutaneous cellulitis without an underlying abscess. The need for preoperative antibiotics for conditions such as abnormal or artificial heart valves may require reconsideration of the timing for the procedure. Input from an appropriate specialist may be important for areas of the body with cosmetic concerns because of the expected scar formation after an abscess drainage. Appropriate universal precautions for potential exposure to bodily fluids should always be used. Materials needed for the incision and drainage of an abscess are similar to those needed for a laceration repair. A pre-assembled laceration kit may contain many of the necessary items. For preparation and anesthesia, obtain a skin cleansing agent, sterile gauze, local anesthetic, and a 5 to 10 milliliter syringe with a 25 to 30 gauge needle. 1% lidocaine is an appropriate anesthetic for this procedure. Lidocaine with epinephrine offers advantages such as reduced bleeding and an extended duration of action, but is typically avoided in areas with a single blood supply. Bupivacaine is another option that offers an increased duration of action for the anesthesia. Items important for the incision and drainage itself include a scalpel blade with handle, a small curved hemostat, normal saline with a sterile bowl, and a large syringe with a splash guard or a needleless 18-gauge angiocatheter for irrigation of the wound. Swabs for bacterial culture, wound packing material, scissors, gauze, and tape should all be available to complete the procedure and dress the wound. Obtain informed consent by discussing the risks and benefits of this procedure, including pain, bleeding, and scar formation. Wash your hands with antibacterial soap before beginning the procedure. Protect yourself from exposure to bodily fluids, as many abscesses are under pressure. A face shield and gloves should be used. Place all equipment on a bedside table that is easy to reach. Position the patient so that the area for drainage is fully exposed. Apply a skin cleanser, such as chlorhexidine or povidone iodine, in a circular motion starting with the peak of the abscess. Cover a wide area outside of the wound to prevent contamination of other equipment. Anesthetize the top of the wound. This should be done by inserting a 25 or 30 gauge needle parallel to the skin and injecting into the intradermal tissues. Once the entire open bore of the needle is under the skin, gentle pressure should be used to infiltrate with the anesthetic agent. You will note blanching of the tissue as the anesthetic spreads out. Continue with infiltration until you have covered an area over the top of the abscess large enough to anesthetize the area of incision. Some abscesses may require additional injections of anesthetic in a local field block pattern or moderate procedural sedation for additional patient comfort. Hold the scalpel between your thumb and forefinger. Make an incision directly over the center of the abscess that is oriented along the long axis of the fluid collection. Resistance may be felt as the incision is initiated, and steady firm pressure will allow a controlled entry into the subcutaneous tissues. Purulent drainage will begin when the abscess cavity has been entered successfully. Cosmetic results can be optimized if the incision is made parallel to existing skin tension lines. The incision should be extended to create an opening large enough to ensure adequate drainage and prevent recurrent abscess formation. It may need to extend the length of the abscess borders. Care must be taken to control the scalpel during the stab incision to prevent puncturing through the back wall of the abscess. The goal is to allow enough access for introduction of a hemostat to break up loculations and place internal packing. Use a swab to obtain a sample from the interior of the cavity for bacterial culture. While most patients will not require antibiotics after an abscess drainage, culture information is useful if the patient's condition later worsens and antibiotic treatment becomes necessary. After allowing the wound to drain spontaneously, gently express any further contents. Additional injections of local anesthetic may be helpful during this portion of the procedure if there is significant patient discomfort. Use a curved hemostat for further blunt dissection to break loculations and allow the abscess cavity to be completely opened up. Insert the hemostat into the wound until you feel the resistance of normal tissue, then open the hemostat to perform blunt dissection of the internal portion of the abscess cavity. Continue this procedure of breaking up loculations in a circular motion until the entire abscess cavity has been explored and any deep tracts that extend into surrounding tissues have been identified. Gentle irrigation of the wound should be performed using sterile normal saline. Appropriate wound incision size will enhance irrigation and prevent excess buildup of pressure within the abscess cavity. The irrigation should continue until the effluent is clear. Using wound packing material, such as 1/4 inch or 1/2 inch packing strips, gently pack the abscess by starting in one quadrant and gradually working around the entire cavity. Place sufficient packing to keep the walls of the abscess separated and to allow further drainage of infected debris. Overpacking may cause ischemia of the surrounding tissues or interfere with desired wound drainage and should be avoided. Appropriate packing will allow healing by secondary intention and avoid premature closure of the wound, which can lead to reaccumulation of bacteria and recurrent abscesses. For a simple abscess, the now openly draining wound allows the body's host defenses to clear the infection without the need to expose patients to the side effects or risks of antimicrobial therapy. After most incision and drainage procedures are performed in healthy patients, antibiotics are not required. Patients with extensive cellulitis beyond the abscess area or with significant comorbidities may require supplemental antibiotic treatment. Providers are encouraged to use their local bacterial culture susceptibility data to guide any such empiric therapy. Community-acquired methicillin-resistant Staphylococcus aureus has garnered heightened attention because of increasing prevalence in skin infections. It is imperative to know and follow your regional management guidelines for this pathogen. Cover the abscess wound with a sterile, non-adherent dressing. Topical antibiotics have a limited benefit and are not required. As with any wound, be certain that the patient's tetanus immunizations are up to date. All abscesses should have packing removed in a few days, and most patients with wounds that have packing in place should be scheduled for a return visit for follow-up and packing removal 2 to 3 days after the procedure. Patients should be given written instructions telling them to return earlier if there are any signs of worsening. On subsequent visits for wound care, packing should be removed to allow assessment of the ongoing healing by secondary intention. Use of fresh packing material may be necessary to continue the healing process if significant wound drainage is still ongoing. A follow-up visit should then be rescheduled for 2 to 3 days later. This is common for abscesses that required extensive drainage. In the absence of other complications, the need for repacking is not an indication for antibiotic treatment. The acidic environment of infected tissue leads to difficulties with adequate anesthesia provided by local anesthetic agents. Using appropriate amounts of anesthetic, allowing sufficient time after injection, or supplementing with oral and parenteral agents can increase patient comfort. Finally, additional complications to watch for include the progression to surrounding cellulitis, development of a fever, or other signs of clinical worsening. These may prompt consideration for repeat incision and drainage of an abscess or the need for antibiotic therapy. Most abscesses will respond well to simple incision and drainage and will not require treatment beyond packing changes and local wound care practices.
This is a video in clinical medicine from the New England Journal of Medicine.
Paraphimosis occurs when the tight penile foreskin of an uncircumcised or a partially circumcised male has been fully retracted behind the ridge of the glans and cannot be pulled back to its normal position. The tight preputial ring can then constrict the glans, leading to swelling and impairment of both lymphatic and venous return. If left untreated, this condition may have severe consequences, including strangulation of the glans and tissue necrosis. This video shows the reduction of paraphimosis in children and is applicable up until adulthood. However, demonstration of the procedure in adults is beyond the scope of this video. In boys, paraphimosis occurs when someone, most often the child, an uninformed caregiver, or a healthcare professional, retracts the prepuce and then leaves it in its retracted position. Paraphimosis may occur after foreskin retraction, self-manipulation, genital cleansing, detailed penile examination, or urethral catheterization. Any condition that impairs preputial softness favors the development of paraphimosis. Examples of these conditions are angiomas, or warts of the prepuce, preputial scarring after burns or inflammation, and preputial piercing, which is usually seen in adolescents. Any patient who presents with a paraphimosis is in urgent need of medical attention. Reduction should be performed immediately. Manual reduction of paraphimosis should be avoided in patients with significant necrosis or ulceration of the foreskin or glans. The procedure should also be avoided in patients with angiomas, warts, or other dermatological lesions of the foreskin or glans. If these contraindications are present, obtain surgical consultation right away to evaluate the need for formal surgical reduction of the paraphimosis. Since many patients are allergic to latex, you should not wear latex gloves during the procedure. Before beginning the procedure, gather the necessary equipment. You will need non-sterile gloves, gauze pads, non-alcoholic antiseptic solution containing chlorhexidine or povidone iodine, and an anesthetic gel or cream that does not contain epinephrine. To prepare the patient for the procedure, explain it in detail to the patient, parent, or caregiver. Obtain informed consent to perform the procedure. Before attempting the reduction of a paraphimosis, it may be useful to administer conscious sedation or inhaled nitrous oxide to the patient in addition to a local anesthetic. Your decision will depend on the needs of the patient and the protocols of your institution. The paraphimosis lesion may be effectively anesthetized by applying a liberal amount of anesthetic gel or cream to the glands and foreskin. After applying the anesthetic, wrap a dry gauze pad around the swollen area of the penis, directly over the anesthetic gel or cream, in order to prevent the gel from leaking. Leave it in place for a minimum of 10 minutes before attempting the reduction procedure. An alternative approach is the use of penile block. Before you begin the procedure, make sure that you are comfortably seated beside the patient, since the reduction may take longer than you anticipate. It generally takes about 10 to 15 minutes until a reduction that uses manual pressure is successful, but it can take up to 30 minutes. The bed or examination table should be at a height that allows you to rest your elbows on its surface while performing the procedure. Once you are sure that you will be comfortable during the procedure, wash and disinfect your hands and put on non-sterile gloves. Place the patient in the supine position. Gently disinfect the genital area using antiseptic-soaked pad swabs. Check the effectiveness of the topical anesthesia before you attempt the reduction. Remove any urethral catheter or preputial implant if present. Carefully inspect the penis to make sure that no constricting bands or foreign bodies are present. If the swelling of the foreskin is moderate, attempt gentle reduction. Using the tips of one or both thumbs, push the glands through the foreskin opening, while simultaneously using the index and middle fingers of both hands to pull distally on the retracted foreskin in order to slide it back over the glands. This step may take longer than expected because the swelling resolves slowly. In patients with severe swelling of the foreskin, reduce the swelling before attempting to perform the procedure. You can accomplish this by firmly grasping the swollen area and gently squeezing its circumference for several minutes. You may need to use a gauze pad to keep the penis from slipping out of your hands. Once the edema of the foreskin has been reduced and the foreskin looks flaccid, you may attempt manual reduction. The paraphimosis is considered reduced when the phymatic ring is drawn back over the glands. Confirm that the reduction is complete by ensuring that the foreskin now fully covers the glands. The patient's pain should be resolved once you have successfully reduced the paraphimosis. If manual reduction procedure is unsuccessful, a surgical specialist should be immediately consulted to manage the situation. To prevent the recurrence of a paraphimosis, inform the patient, parent, or caregiver that the prepuce should be drawn back over the glands every time the penis is manipulated. Instruct the patient, parent, or caregiver that the foreskin should not be retracted for any reason for about 1 week after the paraphimosis has been reduced. A follow-up appointment should be made so that the clinician will be present the first time the foreskin is retracted. This appointment has 2 purposes. It will serve as a teaching session during which the practitioner shows the patient how to clean the penis, and it will give the practitioner an opportunity to make sure that everything has healed. Although minor, the most frequent complication of manual reduction of a paraphimosis is the tearing of the preputial ring. It can be avoided by a gentle but sustained reduction of the preputial edema before the foreskin is slid back over the glands. If tearing occurs, treat it by applying antiseptic solution to prevent the development of an infection. This complication predisposes the patient to preputial scarring and the recurrence of phimosis. Paraphimosis is a urological emergency that must be treated immediately in the emergency department. In most cases, manual reduction, which is the non-invasive technique, is effective and should follow these steps. After adequate confirmation of the diagnosis and a decision that the indication is appropriate, obtain informed consent from the patient, the parents, or the caregivers. Prepare the material and the patient. Seat comfortably, reduce the paraphimosis, and confirm the reduction.